Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of November 17th, 2025. So let's get to our questions. The first question is, can you speak about the Nimbus COVID variant? Many people describe it as a razor blade throat. What are some other signs and symptoms? So let's review a little bit about COVID nomenclature. You'll remember early on in the pandemic we had things like alpha variant and beta and that sort of thing. We've now gotten through the alphabet into Omicron. Most things COVID these days are of the Omicron lineage. And right now, the data that we have is from the CDC about the variants that are out there. Unfortunately, with the recent government shutdown, we don't have a lot of new data, and I'm sure they're working hard to look through the data that they have. So the most recent data that the CDC has is from late August. The most common variant that was circulating at that time was the XFB variant of the Omicron lineage, and that was nicknamed Stratus, and it was making up about 72% of the sample that they had at that time. Subvariant NB1.8.1 was the next most common, and that would make up 11% of the samples, and that's the one that's nicknamed Nimbus. The Nimbus variant seems like it's better adapted at binding epithelial cell receptors, which probably makes it more likely to be transmissible. It isn't better at evading the immune system compared to other variants, and so it's not likely to have a risk of more severe disease. With that variant, there have been reports of sharp stabbing throat pain, and of course we like a good description and a name, so some folks are calling it razor blade throat. But other than that, it seems like it's fairly similar to other variants in that it can cause different degrees of disease depending on the host and other factors. So you'll see the range of people who have minimal to no symptoms, like runny nose, congestion, cough, that sort of thing, to very severe disease like respiratory failure. The good news is that the current vaccines cover the Omicron lineage and should have activity against the subvariants that are circulating, including Nimbus and Stratus. Of course, we'll have to see how things change because they are constantly evolving with this virus. And of course, the folks at the CDC will be looking through the newer data that they have. All right, next question. In Arizona, we have seen a significant increase in the number of hand, foot, and mouth cases. With your knowledge, what places should be avoided during increased risk? Are there any health standards for indoor play places, such as at the mall or indoor trampoline park, for disinfecting surfaces? Hand, foot, and mouth disease is caused by enteroviruses. These circulate throughout the year, but they tend to be more common in the summer and fall. And the nomenclature keeps changing over time, but you may have heard of different groups of viruses like Coxsackie viruses and other numbered enteroviruses like EV71 that can cause hand, foot, and mouth disease. They tend to be transmitted via the GI tract, and thus the name of enteroviruses, but they can often manifest as symptoms outside the GI tract, so things like skin lesions, CNS infections, and respiratory symptoms. For hand, foot, and mouth disease, the incubation period is about 3 to 6 days, and patients are most contagious during the symptomatic phase, but they can shed virus in the stool and saliva for days and sometimes for weeks to months, depending on the host immune status. Viable virus can stay on surfaces for hours and sometimes days, so it makes the possibility for fomite transmission. Of course, in these situations, hand washing is your biggest friend and goes a long way to preventing transmission of infection. Staying at home while acutely ill should help. Since it's a generally mild infection, the AAP recommends that children stay home while ill and then can return to school or daycare once they have no fever, they have no uncontrolled drooling with mouth sores, and they are able to participate normally in classroom activities. In some cases, the local health department may require children with hand, foot, and mouth disease to stay home in order to control an outbreak. Places where people interact should have protocols in place to help keep the surfaces clean, since we know that fomite transmission is possible. There isn't one particular standard out there for what type of cleaning needs to happen and how often. The American Academy of Pediatrics has a book called Managing Infectious Diseases in Childcare and Schools. It's a quick reference, and the latest one is the 6th edition. It's a pretty useful book, and it's worth looking at. They discuss things that you can do to help prevent infection in various situations in childcare and schools. They talk about who should stay home and when, a little bit about cleaning surfaces and disinfecting and other things. Now, childcare and schools are a bit different than other public places, but you can apply a lot of the same principles. In that book, they also reference the National Resource Center for Health and Safety in Childcare and Early Education. That's an online resource that also publishes recommendations about cleaning and disinfecting various surfaces, mostly for the childcare and educational system. So basic surfaces often just need daily cleaning. Some things that are going to be in contact with somebody's mouth, like countertops and toys and that sort of thing, should also be disinfected. But there's variability depending on the situation, including the place and the type of exposure that might happen. So there's not really any major standard that's out there for these public places. The upside to the COVID pandemic is it made people a lot more aware of the potential for transmitting infectious diseases. And during that time, we were pretty aggressive with social distancing and cleaning and disinfecting surfaces. During that time, we saw a very low rate of transmission of other infections, and largely in part because of these different things that people were doing to clean and disinfect and to stay away from each other while they were ill. Now that we have emerged from the pandemic and with fatigue from a lot of things that happened, people aren't being nearly as vigilant about transmission of infections. In a lot of these situations, common sense can be used to keep surfaces clean. If there's high-touch areas that are being contaminated, to clean those areas more often, and to make sure you're washing your hands before and after entering places with high-touch surfaces with lots of people. And of course, if you're changing diapers, especially of a child who's recently had an infection, then wash your hands before and after. If you are doing this in a daycare or a professional setting, then use gloves while you are changing diapers. All right, next question. What are your thoughts on the viral air purifiers that turn from green to red when contaminants are in the air? Are these products worth recommending to parents during cold and flu season to prevent a sick individual from contaminating the whole household? Or are there specific AC filters that can be purchased? This is a great question that doesn't have an easy answer. Interestingly, we discussed air filtration systems in much more depth about a year ago on the ID Talk podcast. And I think it's worth going back and listening to that because we're not going to cover all that ground today. But it's in Volume 5, Episode 3, and it starts at 10 minutes and 25 seconds. But as a basic recap, and then also to discuss the question at hand, there is a decent amount of information out there that the EPA publishes. And so they've got this document titled Residential Air Cleaners, a Technical Summary. So if you search for that in your browser, it comes up pretty quickly, and it has a very in-depth discussion about the principles of trying to filter air and trying to remove particles, including infectious particles. And there are many ways to try to achieve this. You have systems that can be part of the central HVAC system. You can have portable air filtration units. And basically what a lot of these things are trying to do are to increase your air exchanges per hour. Because as you remove old air and put new air, you're trying to remove some of these particles in the air that include infectious particles. They do other things too. There are physical filters. There are things that ionize the particles so they are able to be filtered out more easily. And they do things like use UV light in certain situations. It's important that as you're choosing one of these systems, if you choose to use one of these systems, that you make sure that you're not using a system that creates ozone, because ozone can be a lung irritant. But basically all of these systems are designed to decrease particulate matter in the air, including bacteria, fungi, and viruses. Now, some of these systems have a light or other method of measuring the air quality. And there's different methods that they do this, but some of them will look at volatile organic compounds in the air. How reliable these sensors are, it's unclear, so take that with a grain of salt. There are studies that show that various filtration systems do in fact decrease particulate matter in the air. And there are some studies that show that the quantity of virus particles and fungal spores have been reduced as well. So logic would indicate that the risk of infection should therefore decrease. But there aren't any studies to prove this. This doesn't mean that the filtration systems don't work, we just don't have the evidence to back up the logic. And I'm sure we all know of situations where the logic made sense, but when they did the study, they realized that it just didn't work. Again, that doesn't mean that these filtration systems don't work and aren't beneficial. We just don't know it. So when it comes to home air filtration and decreasing the risk of infection, I think based off of physics and logic, it could be helpful. But whether it's worth the time and the expense, well, that's to be determined. So you can make the decision on your own and see if you want to try something and see if it works for you. Okay, last question. Is there any evidence that shows an increased risk of respiratory infections, either bacterial or viral, for individuals who have had a tonsillectomy, or does the removal significantly decrease the risk of infection? This is another good question, and kind of like the questions that come along here, they're asked because they're difficult and they don't have great answers, and that's the same with this one. We know that the tonsils are part of the mucosal-associated lymph tissue, and it makes up this ring in the oral and nasal airways called Waldeyer's ring. And this is thought to play a role in antigen exposure and development and maintenance of immunity. There are several retrospective studies that try to address the effect of tonsillectomy on the immune system and subsequent development of infection. In a lot of these studies, it really suggests that the overall immunity doesn't change a lot after tonsillectomy, but there are some nuances. For example, T cells, complement, and antibody levels don't seem to change much over long term after tonsillectomy, but there might actually be a short-term decrease in things like immunoglobulin levels. At least in some of the studies, that's what they've noted. But despite that, the immune globulin levels were still actually in the normal range. There are a few studies out of Korea that have followed national data over many years that didn't show an increase in upper airway infections after tonsillectomy compared to controls, but there may have been an increase in deep neck infections. On the other hand, Denmark has some national data as well that showed that there may be an increase of upper respiratory infections after tonsillectomy. So it's really hard to say. We'll have to see what additional data comes to help us better understand this process. As a final topic, I thought I'd talk a little bit about infant botulism. You may have heard that there has been an outbreak of infant botulism here in the United States. The outbreak has been associated with an infant formula by ByHeart Incorporated, and they've issued a recall because of this. At this time, there are 23 infants with suspected or confirmed botulism in 13 states, including a few here in Arizona. Fortunately, all of the babies have survived after being hospitalized and being given immune globulin for the toxin. So botulism is caused by a toxin produced by the bacterium Clostridium botulinum, and it can cause a flaccid paralysis. So the classic disease is caused by older people that tend to eat foods that have the toxin in it, and the classic scenario is inappropriately canned foods. You can also get it by contamination of wounds, and babies can get it by eating formula or other foods that have the toxin in it. Infants present a little bit differently in that they often start out by having constipation because the toxin decreases transit through the GI tract. And so you may have an infant who has regular bowel movements before getting infected, who then go for periods of time with not having bowel movements. And that might be your first hint that there's something going on. The next things that tend to be affected are the facial muscles, and it tends to go from the top down, and so they may not be able to smile as well or keep their eyes closed or have a good suck swallow. And then it can progress to full flaccid paralysis. So it can be dangerous in that it can cause respiratory arrest and death. Treatment involves giving a immune globulin called baby BIG that can be ordered from the California Department of Public Health. This immune globulin binds the toxin and helps decrease the effects of the toxin and can decrease length of stay. If you suspect infant botulism, the patient should be hospitalized and evaluated and watch to see if the symptoms progress. Again, you can order and give baby BIG to help treat, and you can get stool samples to send for confirmation for the toxin. If you suspect that an infant has botulism, touch base with your local health department and they can help coordinate treatment and diagnostic modalities. And if you see a patient that you suspect, there's a test that you can do on physical exam to help look for the effects of botulism. And so one of the things that can happen is that you can get pupillary fatigability. And so you take the patient, put them in a dark room, and shine a light into the eyes and look for the pupils to constrict maximally. And then you take the light away and let the pupil dilate. And then you do that again, and you do that again, and you do that again. And you do that for a couple of minutes to see if the pupillary response fatigues. If it does, that's a pretty good sign that the patient may have infant botulism. Well, that about does it today for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do, and we'll see you next time at the next ID Talk podcast.